And with that, I'm happy to introduce our speaker today, Dr. Les Curtay. Dr. Curtay is a board certified clinical psychologist. He's a nationally recognized leader in the behavioral health and workplace mental health. He is also our behavioral health medical director. So we are honored to have him here today. He's also going to be helping us out with another session in 2026. But Dr. Curtay, as mentioned, is board certified in psychology. His clinical and research expertise spans psychology, neuropsychology, disability medicine, workers' comp, absence management, crisis and trauma response, psychological assessment, and psychotherapy focused on functional restoration, with a distinctive emphasis on integrating psychological and medical care in organizational settings. So, with that, Dr. Curtay is going to take the control of our slides and get going through our session on anxiety disorders.
Thanks, Barb, and thank you for having me, and thanks for making me sound smarter than I actually am. So I will try not to disappoint today.
Not true.
Um, so uh, this is the agenda for today. I want to review some kind of principles around how to make this transition between diagnosis and impairment, which is one of the hardest things for clinicians to do, and it's really hard and the main job in claims, right? That's what people need to do. If I were going to summarize, I'm going to say a lot, and I will try to make it comprehensible and not overwhelming. But if I were going to say the things that I want you to walk away from, it's that work and function are important and they matter more than diagnoses. That being said, getting the diagnosis right really matters. Uh, Translating diagnosis into impairments is hard, but it's our job. And the things I want you to understand about anxiety disorders are that resilience is the norm and treatment is effective, and avoidance is not a treatment for anxiety. Um, and I have been preaching all of those things for a very long time. My children say that it's since before the Earth's crust was fully cooled. So, okay. Let's start with first principles. And please do, as you have questions along the way, please put them in there and we'll do our best to answer them either along the way or at the end. Um, the place to start really for me is always with function. And and this is something that I think that clinicians have a particularly hard time with in wrapping their mind around, but it should come fairly naturally in the claim context, although making the transition can be difficult, right? This for me, I learned this a long time ago from claims people when I first started in corporate settings working in disability and workers' compensation. This is the ultimate question, right? For an individual, what can't they do, because of what, and with what impact on function? That's the provider's responsibility. They need to be able to tell us what the diagnosis is, the because of what can't they do, and what functional impact does that have? Then the claims job is to put that together and okay, so what does that mean? How does that translate into the contract, or in the case of disability, it's the contract. In the case of workers' compensation, it's the regulations and all of the rules and laws that surround workers' compensation decisions. I want to tell you about this model. This may or may not be familiar to you. This is the model from which I always operate. And it's the way that I learned to think about what a person's impairment or capacities are, right? Capacity defines what a person can do. And what that means is that a limitation, on the other hand, what we ask for as a limitation is what a person cannot do no matter how motivated they are. So here I've given you an example, a physical example and a psychological example. Mr. Jones is unable to straighten his left elbow because of an olecranon avulsion fracture. Pretty straightforward and nice and easy to measure. On a cognitive level, Ms. Smith is unable to sustain concentration for longer than 3 minutes at a time. Notice, I'm not saying that this is a reasonable statement or not, but it's specific. This is what I'm saying as a clinician, this person cannot do. Risk, on the other hand, is about the risk of actual harm, and a restriction should always be a statement of what a person should not do, lest they cause harm to themselves, actual harm to themselves or to another person. I'm emphasizing actual harm because of what comes next when we talk about tolerance. But again, here are the examples, right? Here's an elbow example. Ms. Smith should not focus on a video screen tracking airplanes due to risk to others caused by inattention. Right? So actual potential harm to others is the basis of this risk. Again, not saying that it's reasonable or not. That's part of the question that we have to answer. Everything else that isn't about a limitation of ability or a risk due to harm, everything else is tolerance. It is about what a person will put up with under given circumstances, and that changes, right? We're all willing to do some things under some circumstances and not under others. It's important to bear in mind that tolerance is something we cannot measure. There is no scientific way to measure this. We can assess it by having conversation with people, but we can't measure it, we can't put a number on it, and it should never be the basis of a restriction. This is Dr. Curtay's point of view, right? We should not be having tolerance as a basis of a restriction because it's not about actual harm. At the same time, it's not just tolerance, right? It's not something we get to ignore. Somebody has pain that is not causing actual exacerbation of an injury, that is a tolerance question. That doesn't make it irrelevant, but it does make a difference in terms of how we think about it with restrictions and limitations. And we'll come to that as we go along. Why does this matter? And here it is. Being out of work is terrible for your health. When I first started talking about workplace mental health and in the disability space initially, the best I could say was that we didn't have any evidence that being out of work is good for people. Well, I can definitively say at this point we have overwhelming evidence that being out of work is terrible for people's physical health and their mental health. And in fact, there are substantial increases in mortality risk, people dying because they're out of work. So I don't take this lightly. And as far as I'm concerned, especially taking somebody out for a psychiatric condition, that should be treated as a medical emergency. This is a really bad thing for people. All the risks here are all the risks: substance use and abuse, mental health conditions and symptoms, divorce, domestic abuse. You see the list here. My favorite quote here from Gordon Waddell: if a medication had the same adverse outcomes as a sick note, we would consider it malpractice to prescribe it. In other words, we should take these things really, really seriously and manage it in such a way that we're taking account of how's a person feeling and what do they need in terms of support. But also, this should be as short as possible for their own health. And that's why I always start with talking about impairment and what it means. Again, so my first point, work and function matter more than the diagnosis. That being said, getting the diagnosis right makes a difference. If we were in a group together and I could actually see you, I would ask, everybody in the room who has not been anxious in the last year, raise your hand. I will tell you that when I do that in front of audiences, there's always one smart aleck who raises their hand. But we've all, there you go. Thank you. Thank you, Barb, for being that person. Um, the, anxiety, my point here is that anxiety is not a diagnosis. Anxiety is a symptom, it's a psychological symptom that under certain circumstances warrants a diagnosis. The level of anxiety that we have, the level of arousal in the nervous system, has an impact on performance. Too low reduces performance. When I teach at the university, I tell people if you have absolutely no test anxiety whatsoever, you won't do that well because you won't take it seriously. On the other hand, if you have too much, that reduces your performance because you're too anxious and distracted and you can't keep up with it, with the demands. This has been around. This paper, this is Yerkes and Dotson, is a 1908 paper. This idea really captures the fact that from virtually all psychological traits are distributed on a continuum. And that's really incompatible in some ways with the whole idea of diagnosis. If anxiety is a spectrum, at what point along the way do we decide that it is a disorder that requires treatment? And that's part of what the clinician's job is for us, is to help us understand. Currently in DSM-5 text revision, that's the current edition of the Diagnostic and Statistical Manual, these are the things that I call as anxious disorders, meaning that anxiety is a substantial component of the diagnosis. So the anxiety disorders, which we'll talk about separately, the obsessive compulsive and related disorders, and trauma and stressor-related disorders. These used to all be lumped together in DSM-4. They've been separated out in DSM-5 because they also have, although there's overlap, they also have some differences in the way that they manifest. So here are the anxiety disorders. There's a list of all the anxiety disorders that are in DSM, and I've highlighted in blue the ones that we most commonly see in a claims context. You will see social phobia, or what's now called social anxiety phobia, panic disorder, agoraphobia, and generalized anxiety disorder. I would say that when I'm looking at files, when I see records in a file, most of what I see is generalized anxiety disorder. I will sometimes see panic attacks or panic disorder. And agoraphobia is usually associated with panic disorder, but not always. And it's really about constricting one's mobility to staying in a safe place or a place from which escape is possible. So we see that a lot in connection with panic disorders, that somebody gets anxious about being out in a space where they cannot easily get away. Sort of a misperception is that it always means that somebody only feels safe at home. That's not quite true, but that's one of the ways that it often manifests itself. In the back, in the appendix, and Barb, I'm going to actually confirm something with you if I can.
Sure.
That they will have access to these slides.
Yep.
Okay, so in the appendix, I've put in more detail about each of these kinds of disorders. My job here isn't to teach you everything there is to know about these anxiety disorders, but to give you a high-level overview. The most common obsessive compulsive and related disorder that I think in claims that we'll see is obsessive compulsive disorder. Obsessive compulsive disorder involves obsessive thoughts So thoughts we can't get away from, and compulsive responses to that. Um, Again, I can't see a show of hands. I can't see your faces. So the thing to ask yourself is, have you ever left your home and then had to turn around because you couldn't remember if you locked the door or not? That is that obsessive thought, that worry about whether I locked the door or not, it feels like a real compulsion, like I've got to go back, right? I've had that experience where I've done it 3 times. Um, Now, I don't have OCD. I don't have an obsessive compulsive disorder, but an exaggerated form of that really gets in the way of my ability to function in life, that makes an obsessive compulsive disorder. So again, it's kind of a spectrum, right? We all have had that experience. I saw all the thumbs ups. it's,
I
it's
was wondering
like,
if you saw them.
yeah, yeah, we've all done that. We've all like gone to bed and then worried about whether we actually turned the stove off or a heater in another room, right? Again, it's a spectrum. There's a normal manifestation of this, and then there is a manifestation of this that gets in the way of just living life. And that's the difference, right? We see that a lot. Sometimes I will see body dysmorphic disorder in claims. We used to put this under somatoform disorders. It's actually been lumped into OCD and related disorders because it's very much so. Body dysmorphic disorder is I have some physical feature that I am convinced is so ugly that people will reject me because of it. Um, and so although objectively there's no difference, had a patient who was convinced that her ears were so large that people thought she was ugly. She would go out of her way to cover her ears with a hat to make sure that her hair was in such a way that you couldn't see her ears. And it really interfered with her ability to be out in public. Sometimes we see that, but it's a kind of an obsessive compulsive disorder. I'm obsessed. I have this obsessive idea that something is wrong with me, and I change my behaviors in such a way that I'm trying to manage that anxious thought. And that's what's happening in these disorders is the compulsion is designed to relieve the anxiety. Usually it only works very briefly, and that's why it gets in the way, but that's what it's trying to do. Um, Oops, I think I skipped over something. Pardon me. Oh, trauma and stressor-related disorders. Again, these used to be lumped in with anxiety disorders because anxiety is an important part of them. Um, and adjustment disorders were carved out. Now we've put them all together. And these are the 3 things you're going to see most commonly: PTSD, acute stress disorder. I want to say this because it gets really confusing in claims, partly because people sometimes are sloppy about the diagnosis. Acute distress disorder is the exact same symptoms as post-traumatic stress disorder, but for less than 30 days. So for the initial 30 days, it's acute stress disorder. If it goes beyond 30 days, it becomes PTSD. You cannot have both diagnoses at the same time, technically speaking, but we see it in claims all the time. Basically, it's the same thing. It's not 2 different diagnoses. Adjustment disorders are also stress responses that are out of proportion to a stressor, but they don't meet criteria for PTSD. But it's the same essential idea that something has happened. I have a reaction to it. It interferes with my function, and the symptoms are out of proportion to what we would expect. I want to be especially careful, and I encourage you to be especially careful when people have diagnosed PTSD. PTSD requires these diagnostic criteria. Again, in the appendix, this is more carefully spelled out. But essentially, the number one criterion is what we call criterion A. Criterion A is exposure to an actual or threatened death, serious injury, or sexual violence in one or more of these ways, and it spells it out. Each subsequent edition from DSM-3 has expanded the definition slightly. Nevertheless, it requires this. This is the place where diagnostically I most often see mistakes. To put an extreme example, getting yelled at by your boss in a meeting in public is humiliating and unfortunate and bad behavior on the part of the boss, but it's not a criterion A event. Nevertheless, we see that, right? We see diagnoses based on things that do not qualify for criterion A, and that's not PTSD, even if you have all these other symptoms. It also, however, being exposed to a criterion A event doesn't necessarily mean that a person has PTSD, because it requires symptoms of intrusion, meaning intrusive thoughts about the event, nightmares, repetitive thoughts that you can't avoid, avoidance of reminders of the event, changes in cognition and mood, and increased arousal like hyperreactivity. Those are all things that are required to make this diagnosis. I belabor this. Oops, did I lose sound? Oh, there we go. Okay.
I,
You can hear me okay?
I can.
Okay, great. I belabor this point a lot because exposure to criterion A events is actually quite high. Right? By the time you're an adult in the United States, 90-ish%, it varies a little bit based on definition and the study, but about 90% of us have been exposed to a criterion A event. Nevertheless, the lifetime prevalence of PTSD is about 8%. So a little less for men and more for women. The difference between men and women is almost exclusively driven by the incidence of sexual assault. But what's that tell us? What that tells me is that exposure to a criterion A event is common, and the least likely outcome of that exposure is PTSD. Most people, when we experience a traumatic event, we get shaken up and then we get better. That is the most common response, and that's a really important idea, because I think, unfortunately, we're seeing a change in culture that suggests that if you've had a traumatic experience, that you're forever damaged, and that is not true. And we'll get to that in a minute in terms of treatment. But that's why it's important. I'm going to use this example. If you're from Chicago, you'll call this the Sears Tower. If you're, for anyone else who's been to Chicago, and at the top of this tower, it's the Willis Tower. It's a little glass cage. I call it scary. Yeah, exactly. I was standing on this glass cage at the top of the Sears Tower. I'm from Chicago, so it will forever be that for me. I felt completely and utterly unable to take a step forward, right? The question is that an issue of tolerance, or is it an actual limitation? And I'm going to come back to this in a minute, but this is really how it shows up, right? I feel unable to take one more step forward. It's like I'm pressed up against the wall. And that was actually what my experience was. I'll tell you the rest of the story in a second. But that's the way that it shows up, right? I'm anxious. I feel incapable of doing more. Couple more things, Sears Tower forever. Go you. um, Couple more things about diagnosis. We see, especially I see in anxiety, depressive disorders, and PTSD, we see positive screening measures, and a diagnosis is based on that. So you guys go to your doctor and you fill out some form of, you respond to questions that are some form of a screening measure for depression and anxiety, probably not PTSD, but it's used a lot. And it's a positive screen and you get a diagnosis. That is not how it works. Screening measures are indications that somebody has symptoms that should make us inquire further. We don't accept screening measures as a criterion for a diagnosis. Okay, so I've been talking a lot, I've been talking fast, so we'll have a poll question for you that will get put up on your screen. And I am going to continue on. This will stay up until people have had a chance to answer. But I'm going to continue on with the talking here. I'm going to close that out of my screen. It pops up in front of my screen, but unfairly enough, I don't get to vote, although it would be cheating in my part, as Barb pointed out earlier today.
Definite cheating.
Um, okay, so now how do we translate anxiety and anxiety disorder? How do we translate the symptoms into limitations and or restrictions? By the way, notice that limitations and restrictions is not a single 8-letter word. It is, they're two separate ideas. And the question that to ask in terms of limitations that I alluded to is, I felt in this moment completely and utterly unable to move forward. The question is, am I actually incapable of moving forward? That's the question that we have to ask ourselves. And is there a risk of harm to me, right? It's very likely that if I forced myself or somebody pushed me, I would feel more anxious. The question is, am I at actual risk of harm if I am forced to move forward? And the question that I love to ask providers is, if Joe wanted to work, sorry for anybody in the audience who's named Joe, if Joe wanted to work, would I let him? When I've had conversations with providers, you'd be surprised how often the answer that I get to this is yes. And if the answer is yes, that tells me two things. That tells me that the provider doesn't believe that the person is incapable of doing it, and it tells me that they're not restricting them because of harm, right? So now we can have a conversation about how do we get them back to work. Long story short, if it's not one of these two things, it's a question of tolerance. Now I'll tell you the rest of the story. I had my two youngest children with me when I was here. They, of course, are completely and utterly fearless and run out into the cage. And my 4-year-old fell down on the other side of the cage. Guess what I did? I immediately went and picked him up, right? Which tells you the story. It's a tolerance issue because absent any additional or different motivation, I wasn't able to move. But as soon as I had a different set of circumstances, I did what I had to do. Of course, I'm a parent, right? I went and picked him up. And that's the way to think about tolerance, right? What are the motivating factors? It's not that it's irrelevant. It's just that it isn't actually a limitation and it doesn't require a restriction. And by the way, when I got there and I picked him up and I looked down, I did in fact feel more anxious, but it didn't kill me. And it didn't really cause me any harm. and it's not a criterion A event. I don't get to claim PTSD because I got scared being over there. But this is the best example that I can think of the distinction between limitations, restrictions, and tolerance. Again, it's not just tolerance, it's important, but that's the way to think about it. If we try to translate symptoms, psychological symptoms, into impairments, this is one way that that we can think about it. There are these dimensions, and there are 4 here and 3 more. So one is social and interpersonal functioning, communication, attention and concentration, learning and memory. I'll skip ahead and then come back. Persistence, pace, and adaptation. Persistence, pace, and adaptation you see a lot in Social Security records. Right? So what does this look like when we actually make a reasonable statement about a behavioral dimension? Ms. Smith's extreme social anxiety impairs her ability to speak publicly or in group settings. That's actually a pretty good statement of a functional limitation. On the other hand, Ms. Smith cannot work with the public is probably an overstatement and not very helpful. Communication. Mr. Smith's anxiety aggravates his stutter and makes it difficult to communicate in highly stressful settings. Again, it's very specific, right? It is in the area of communication, but again, much more helpful than can't work with the public. And I won't read them all, but you get a sense here, if you look at them, about how to turn these things into specific limitations and restrictions, which, if you're in claims, allows you to compare those things to actual occupational requirements, right? Okay, Ms. Smith has trouble speaking publicly in a group setting. Is that part of the job? If it's not, then it's a restriction, it's a limit, or it's a limitation. It's a limitation, not a restriction. Again, because Ms. Smith would not actually be harmed by speaking in public, but it's a limitation. It's hard, right? It's difficult for her to be able to do it. But it could be totally irrelevant to work. I don't think I'm telling you anything you don't know, but I'm trying to take things from the physical realm and put them in the context of a psychological condition so that you can make that transition. Excuse me. Here's some more examples in persistence, pace, and adaptation, right? Mr. Smith's anxiety impairs his ability to sustain work output without hourly breaks. Notice I'm not evaluating whether this is reasonable or not, but it's nevertheless, it's something that I, as a medical professional, as a health professional, I can validate this to help with a claims decision, and you can then compare it to job requirements to see if it's manageable. Can the person do their job with that accommodation? So you see the example. The point here is to be as specific as possible. Pardon me. The point also is to help the providers be as specific as possible. One of the unfortunate things that I think happens, especially in disability, but to some extent in workers' compensation as well, that we ask treating providers to give us restrictions and limitations without explaining what those are. And what happens next is that we immediately begin to argue with them about how they're wrong. Well, we haven't taught them this. We haven't taught them to be specific, so we don't we ask an open-ended question, that isn't helpful for us in making a claim decision. But if you take these dimensions and start to think about, well, how does this translate into actual job tasks? I think it makes working with anxiety disorders easier to understand. Okay. I also told you that um, that treatment is effective and it's possible to make things better. This is what I said about PTSD, right? The most common reaction to um, the most common reaction to an adverse event of any kind is that we get shaken up and we get better. That's true of physical conditions as well as emotional conditions. We forget that. I have asked the question sometimes in large rooms full of claims people, what's the most common response to an injury or illness that takes somebody out of work? And I'm often surprised at how long it takes to come up with the right answer, which is people get better and go back to work. Because we spend all of our time and energy on claims where that doesn't work the way that it's supposed to work. It takes up all of our time, but this is the most likely form. Second most common pattern is recovery, which is gets shaken up a little bit more, takes a little bit longer, but nevertheless we get better. And then long-term dysfunctional coping is the least likely outcome. Um, Anxiety disorders respond to two things. And all effective treatments are going to have some version of these two components: exposure and response prevention. Exposure and response prevention is actually a specific methodology that was developed for OCD, but it's true generally across all things that involve anxiety. What does this mean? You cannot overcome something that makes you anxious without actually being exposed to it. If I'm terrified of driving over a bridge, I cannot get better from that anxiety without actually being exposed to driving over a bridge. Basically, mom was right. When we fall off the bicycle, we have to get back on. Why? Because if I'm anxious about driving over a bridge and I go out of my way and drive an extra 50 miles so that I don't ever have to drive over a bridge, I won't ever get better, because every time I avoid it, I reinforce the avoidance. It gets stronger over time. So when someone is anxious, this is the one that drives me crazy, is, you know, my my patient can't go back to work because going back to work makes them feel, thinking about going back to work makes them feel anxious. Well, we don't prescribe avoidance for any anxiety disorder. The longer somebody stays out, the more reinforcing it is to stay out of work. And so the worse the anxiety gets, right? The way that we deal with this is gradually expose people to reminders of work and then eventually to the work setting. That's how we do it. So the response prevention piece is we don't let people avoid it, and we create alternative responses. We help them create a way of thinking about them, um, and that's this is the common thing in all aspects of treatment for any of these disorders that are based in anxiety. And by the way, I'm seeing great questions pop up, so I'm going to try really hard to leave time to answer them. So here's another polling question for you. It's critical to be specific about the behavior, its relation to the cause, and the likely duration. I
And
will.
Les, we had an interesting comment that came through earlier on about the fact that some of the folks or at least one person says that they're seeing PTSD diagnoses brought up 1 to 2 years after the event.
Yep. It can happen. It's actually a very rare manifestation, but it does sometimes happen. What I want to know in that circumstance from a clinical perspective is how has the person been impacted in the meantime? Have there been any other events that may have contributed to this becoming a problem later? It's pretty unusual, frankly. Um, the basis of this is that people sort of suppress or repress the memory or the feeling that they had at the time, and then it comes up later. If you think back to adverse events that have happened to you, it's actually really very unusual to have forgotten them. Mostly we
Sure.
remember them quite clearly. So it does happen, but I have questions as a clinician, and the questions are important in the claim context of how's this person been doing in the meantime? What has happened? And how do we think about those things in a reasonable way? You know, unfortunately or fortunately, depending on the resources you have available, this is where a clinician can really help you, right? To look at the information but the questions for a claims person to be asking is, what's been happening in between? What has this person been doing? And certainly, if they've been in the same situation that they were in without triggering it, then it makes it a little less credible that this is now PTSD.
And I imagine what you're saying is that those would be likely or could be very good questions to be asked as an IME provider or a peer review provider was weighing in on a particular
Yes.
diagnosis from another provider.
Yep. Yep.
Okay.
And actually it's a great question in another way because it helps, for example, if you're formulating questions for an IME or a peer review, that should be a very specific question, right? The question isn't what are the restrictions and limitations? The question is, you know, um, can is it reasonable based on the records we have available? Is it reasonable to build a bridge between the original event and current symptoms?
Mhm.
Help somebody do that. If I were in work comp and I were asked to do a causation analysis, that's what I would be going through. Can I connect the dots from this event to this later occurrence? And it has
Sure.
to be more than, well, it makes sense because it was a traumatic event and now they have symptoms of PTSD. It's got to be
Mhm.
more than that. I need to be able to build that bridge. So it helps
Right.
me formulate a specific question.
So to that point, it sounds to me as a non-clinician that an IME might end up being a behavioral health IME might end up being a better choice than a peer in this situation if the treating provider hadn't probed in those areas. Am I right?
Um, if I had other records, like from a family practice doc
Mm-hmm.
who was documenting along the way that the person was describing, anxiety or describing nightmares or whatever, that might be enough for me to kind of help connect the dots.
Sure.
The the problem with I mean, yes, ultimately, if I don't have anything in between, then ultimately an IME might be better.
Right.
The problem with the IME is now I'm examining someone now for an event ostensibly that occurred 2 years ago.
Right.
That's really tough,
Sure.
right? It's a
Sure.
tough position. So the question is, do you have enough records to build a reasonable bridge? And if not, then you don't have any choice but to do an IME.
Right.
Um, the other thing that I would say is that the most important questions for the IME is going to be less about connecting the dots than about what can the person do and not do right now, right? The
Gotcha.
functional questions are going to be really important. I recognize that in work comp, causation is an issue that has to be settled, but the IME is going to have a hard time making that bridge. That's going to be more likely to come from records. That help?
Yep,
Great
very much.
question. Great question. Um, okay. Basically, what this slide essentially says is that people get better from PTSD. Again, my point being, so people get exposed to criterion A events. PTSD is less likely than anything else. By the way, even in combat exposed veterans, the incidence of PTSD is less than 20%. So 4 times out of 5, people who have been clearly exposed to combat criterion A events, 80% of those people will not develop PTSD. When they do, half will recover within 3 months of onset. There is a study here that's cited that they generally recover within 3 years and without treatment twice as almost twice as long. I would venture to say that under competent evidence-based treatment for PTSD, 3 to 6 months is closer to what we should expect than 36 months. 36 months is a long time. And that's what I think we should expect to see. I put here from MD guidelines the duration days, minimum, optimum, and maximum. For those of you who use MD guidelines, or if you use ODG, the numbers are quite similar to this in terms of their meaning. Minimum means the number of days that is, if nothing got in the way and everything worked exactly the way that we wanted it to, and this person was highly motivated, they should be out around a week. The 28-day optimum means if it goes past 28 days, we ought to be asking questions. That's the
Okay.
point at which we should say, it should have gotten better enough, not completely well, but better enough that this person can be back to functioning within a month. And if they're not, we should start asking why. So it gives us a way of thinking about it. And then maximum is like, if you're over that number, there's something that's complicating this picture that needs to be investigated. And what could be complicating it is that they're not getting good treatment. But there's a complication that really needs to be focused on. So that's the way I put this in here, partly to give you a sense of how to use those numbers and make
Mm-hmm.
sense out of them.
That's really helpful.
Okay. This is how treatment impacts functioning. Sometimes people get temporarily increased symptoms. Anxiolytics have their trouble. I will say that prescribing an anxiolytic like Xanax for an anxiety disorder without therapy actually has worse outcomes than doing therapy without the medication. Why? Because taking a pill that reduces anxiety is a form of avoidance. And so if that's all that's happening think back to exposure and response prevention. If all I'm doing is avoiding the feeling of anxiety, I am not getting better. I have to have some component of, I need to work through this in a different way. So these things will just give you a sense. I won't spend a lot of time here. unless we have questions. So here's the bottom line. I'll leave us a few minutes anyway for questions. Um, Anxiety is common. These disorders share common features. Resilience is the default that we should be thinking. We should be expecting people to get better. Avoidance is self-reinforcing and by itself doesn't work. Treatment should always include exposure and response alteration or response prevention. And we generally have pretty good outcomes in short timeframes. So with that, here's the last poll question. Make sure that everybody's still awake at the end of the presentation. And
I can pose some questions for you if you'd like.
I'd like that very much.
Okay, great. We've got what would be the determination for recovered from PTSD? Would symptoms still be present years later, like sleep issues, anger, depression? And if those symptoms are still existing, is it still considered recovered?
So I will tell you my perspective. My perspective, especially in the disability and work comp space, is that I want that person back to a level of functioning that allows them to be productive and be meaningful, engaged in life. And so my answer to that question is probably yes, that I'd consider them recovered unless their symptoms are such that it really interferes with their life, in which case I want to know more about the treatment. This is with mental health providers often a real problem because as a psychologist, I never want to give up on anybody. And I always think they could be better. Again, raise your hand if you couldn't stand any improvement in your mental health.
Mhm.
Truthful people wouldn't raise their hand. But so it's not about being perfect. It's about being better enough to be functional.
Okay, great. Then we've got specifically regarding anxiety, panic, and PTSD, which is what we see often on the comp side of things. I'm curious as to why many clinicians are not utilizing EMDR treatment for PTSD when there is a specific traumatic event. Is this something that is not heavily utilized in mental health?
So I have mixed feelings about EMDR. But if you think about EMDR and why it works, what's happening in EMDR is that so you have a person call to mind a traumatic event or something that feels traumatizing, and then you have them do different things. You have them follow your finger with your eyes, or have sensory changes. You're touching people on different sides of the body. So what's happening? You're exposing the person and you're distracting them. It is exposure and response prevention that works. EMDR is not magic by itself, and it, contrary to the theory, I don't think there's any evidence that there is neurologically a difference from the eyes following, but it is exposure and response prevention. So lots of people don't do EMDR, but they do graduated exposure. They do other forms of evidence-based treatment. But that's what you should be looking for. Don't look for EMDR. Look for, is there graduated exposure and some retraining of cognition that's involved in it?
Okay, great. Another question is, could you give us a summary of how you would phrase your conversations regarding restrictions and limitations to providers?
Wow. In 30 seconds or less, right?
Right.
Um, Actually, the truth is that I often start with some version of if your patient wanted to work, would you allow them to do it? Because I want to understand what they actually believe the person is capable of
Hmm.
and what will hurt them. And if the answer is yes, then I'm going to have a conversation with them about, okay, how do we get this person back to work? If the answer is no, then I want to know more detail about, okay, what is the harm, right? What is the person actually incapable of doing? So I should try to get at the specifics. I can't answer the question exactly because a part of my conversation would be based on what I see in the records,
Okay.
right? So I'd be asking about the treatment protocols and all of those things, but that will vary.
Okay. We have two other questions and then we're going to have to end it because we're at the hour,
Understood.
but there is a really good one for individuals with PT. Yeah, I want to make sure I'm on the right one. For individuals with PTSD, anxiety, would natural relaxation strategies like meditation, therapeutic massage, breathing, mindfulness, I'm going to throw in yoga, would those be appropriate interventions?
They can be helpful. They won't be helpful without some element of exposure.
Okay.
Um, and in fact, if you teach someone mindfulness, for example, mindfulness meditation, and that's all you do, sometimes it will actually increase the anxiety. Because what happens when you settle your mind and you start paying attention is you start to ruminate about the things that are underneath it. So, so it's really important to have some guidance around having both elements, exposure and response prevention.
Okay. And then the last question we have is there a difference in outcome between virtual exposure and direct exposure?
It's still really forming in the literature, but the answer seems to be not much. And virtual exposure is actually quite effective in a lot of circumstances. It will depend a lot on the patient, it will depend on the circumstance, but there's real promise in virtual exposure.
What does virtual exposure mean? I'm
Well, I hopefully I'm answering the question the way it was posed. There's two ways to think about it. One is if if you're afraid to get on a plane,
Mhm.
I don't need you to actually get on a plane in front of me. I need you to be able to do it mentally.
Okay.
That's where I start at least, and then eventually we get to getting on the plane for real. But also there's also virtual reality exposure treatment
Oh, okay.
that has some real promise to it, but it's still early.
Gotcha. Okay. Well, gosh, we are over the hour and it's been a great session. We've got lots of great feedback. It sounds like really people enjoyed the session. And thank you, Dr. Curte, for collaborating with us on this and bringing this up, especially at this time of the year. I think it's an appropriate topic. They always talk about how, the holiday blues and so on and so forth. So whether it be for those of us in our own personal lives and or those claimants that we're working with, I think it was very helpful. Thank you, thank you. Happy holidays, everyone. And you will hear from Dr. Curte again in 2026. I think he's queued up to do a presentation with us in June. So we'll talk soon.
Okay. Thanks
Thank you.
very much. Thanks for
Have
having
a
me, and
wonderful
thanks
rest of the
everyone.
day.